All right, how's it going, guys? So we are on to topic 8.5, trauma and stress-related disorders, dissociative, and finally somatoform and related disorders. So let's get after it. Let's start with trauma. Okay, so we're going to start with trauma and stress-related disorders. This category, we're only going to talk about PTSD. The other ones haven't really seen on the AP exam. So PTSD. All right, so post-traumatic stress disorder. This is a disorder that I feel most students have a decent grasp of what's going on. A patient has been involved in some sort of traumatic event, and that traumatic event just won't go away. And so what you have is you have a patient that is constantly working to avoid situations that are similar to that event. They are haunted by it. So patients with PTSD often struggle to sleep at night as they are harried by these nightmares. They often attempt to avoid situations or places that are similar to the traumatic event. A simple example of this might be someone who gets in a really bad car accident. Generally speaking, you don't want to go back and get into a car very soon afterwards. And if that was something that stuck with you, you might be very uncomfortable and try to use other methods of transportation in order to get around and avoid using a vehicle at all cost. So that's PTSD, high suicide rate. It you know it's a pretty tough disorder, and once again, you're just dealing with the nightmares and the trauma that had hit you before, just keeps coming back over and over and over again. Okay, so that is PTSD. Okay, so next we're going to go into dissociative disorders. So dissociative disorders deal with a disruption in how our cognition or our personality or our behaviors function, the way in which we handle ourselves, the way in which we do things. And so this is going to be a break in that structure and how those things are done. So we have two major dissociative disorders that we're going to talk about: dissociative amnesia and dissociative identity disorder. So dissociative amnesia is amnesia. You know what this is. This is where you forget something or a block of time, and the reason normally you would see this as biological, where you get cracked in the head, but dissociative amnesia means that it is amnesia with no biological backing. There's no physical damage to the brain. Most often, dissociative amnesia stems from some type of trauma, person having trouble dealing with something that is very extreme. So there you go. That's dissociative amnesia. Easy peasy. Next, we have dissociative identity disorder. So this used to be called multiple personality disorder, which might help you remember or recognize what this is. The disorder is no longer called that, so make sure that you call it DID, dissociative identity disorder. This is the change that was made in the DSM-5. DSM-4 called it multiple personalities, and this is a person that has multiple personas. This can be as many as just one or five or even more than that. If you've seen the movie Split, they do a fairly good job of showing what that might look like, minus the superpowers. But this is a person who has multiple personas within them, and there are different names, different ages, different personalities, different interests. There's still quite a bit of controversy over, the validity of DID, whether or not it's completely true or a figment of people's imagination. But generally speaking, it's accepted. And when we're looking at someone with DID, what is the root cause generally with this disorder? And usually the root cause stems from trauma, and a patient a patient's personality is a way for them to cope with that trauma. So you have a child who's, you know, being bullied or hurt, and this new persona comes out in order to deal with that specific problem. And so now they have those two personalities, one of them to deal with really bad situations, and the other one that, you know, just kind of lives life as normal. How much interaction there is dependent on the person. Some people don't even know that they have multiple personalities living within them. Some of them interact with them and know and, like, you know, have conversations with each other. Um, Lots of variation with this, but just knowing the basis will be good. All right, so next we have somatoform and symptom-related disorders. Okay, so with this, we are looking at a patient that has some sort of physical, or excuse me, some sort of psychological problem that stems from a physical ailment. So something physically is wrong with them, and that has created some sort of psychological issue. So two of these go with this. So the first is illness anxiety disorder, also known as hypochondriasis. If you watch any doctor show, they will have an example of a hypochondriac. Basically, patients with illness anxiety disorder have very small physical symptoms. I've got a tummy ache, I got a headache, my throat's a little scratchy. And what they do is they blow that problem out of proportions, believing that it is much more dire of a situation. I have cancer, I have some rare disease that you can only catch in the Mediterranean or something like that. And you know, the problem comes from their maladaptive behaviors where they have difficulty accepting that, you know, it's just a small issue, and so they go to the hospital oftentimes, getting, you know, multiple checkups in order to try and sort out, you know, what is wrong. And, you know, you run into the fact of, you know, you're spending thousands and thousands of dollars, and insurance companies are no longer covering you because you're going to the hospital all the time for little aches and pains. And you can imagine how much money gets spent and how much time is wasted worrying about very, very small things. All right, the last one for today is conversion disorder. So conversion disorder is similar in vein to illness anxiety disorder, but here what is happening is the patient reports or believes that there's the existence of some sort of severe physical problem, but there's no biological backing to it. So the patient gets shot in the leg in the military. They go to therapy, or, you know, they go to the doctor, they get it fixed, they go to therapy, they work it out, but in their head, they just are so used to walking with a limp, walking with a cane, that even though the leg is fully healed, they are still walking with a limp. And it's just something that's mental, this mental block that, oh, you know, there's still a problem here, even though there really isn't a problem. So again, you're believing that there is some sort of physical problem when in reality there's absolutely nothing wrong. And when you would go to the doctor, they'd say your leg is fine, you should be able to walk on it fine, but there's a mental block there, and so they're not able to use it properly. So, all right, so that's it for today. This is topic 8.5. Thank you so much for stopping by, guys. You all have a good one. See you later.